All right, so we will go ahead and get started. Thank you everyone for attending our second webinar today of the Improving Childhood Obesity Care, a Grow Healthy series. We are going to get started. And as you come in, please share where you are based in the chat. We would love to hear from you, know where you're coming from. All right, next slide, Daniela. Thank you. Okay, so like I said, today is our second webinar of the series. I'm Brooke Schoenenberg. I'm a project manager with Grow Healthy, and I'll be moderating our training series today, and I look forward to having an engaging session with you all. So what is Grow Healthy? It is an evidence-based public service initiative grounded in decades of childhood obesity prevention and treatment research from Pennington Biomedical. Pennington Biomedical is a world-renowned research center that promotes metabolic health and eliminating metabolic disease through scientific discoveries. So please visit our website at growhealthy.org for more information. Next slide, please. All right, so we are hosting a series of webinars. Our recording from the one that we did in March is posted on our website, so please visit our website if you'd like to see that one. It was led by Pennington Biomedical's very own Dr. Amanda Stiano with Dr. Alyssa Button and Angel Ulmer. They presented on IHBLT, which is Intensive Health Behavior Lifestyle Treatment, Motivational Interviewing, and Behavior Change Strategies. And today, of course, we have Dr. Queen, who I will introduce shortly. And then our next webinar will be on July 17th with Dr. Zubi Noor Hanapa from Metamore and Grow Healthy, where she'll be presenting on the efficacy of metabolic and bariatric surgery in adolescents. And so please note that CME credit is only available for live sessions, including this one. All right. We have recently launched a childhood obesity prevention evaluation and treatment toolkit for providers that is available online through our provider hub. You have to fill out a quick form and then you'll be able to have the toolkit at your fingertips. It's a great way to either be introduced or refreshed on the AAP clinical practice guidelines that were released in 2023. So Dr. Queen, who's presenting today, was heavily involved in the creation of our provider toolkit, the Grow Healthy Provider Toolkit, and we will place a link in the chat to download it. So we are also excited to announce that we are hosting a conference in October. It is called Be the Reason Kids Grow Healthy Childhood Obesity Conference. The dates are October 2nd and 3rd, and it's going to be held right here at Pennington Biomedical Research Center. So we hope to see you all there. All right, next slide, please. This is the accreditation and credit statement from the Louisiana AAP, which we have coordinated with to offer today's CME credit for free. So very exciting. Thank you. All right, next slide, please. All right, so now I get the pleasure of introducing today's presenter, Dr. Katie Queen. Dr. Queen is double board certified in both pediatrics and obesity medicine, and she's the medical director of the Pediatric Multidisciplinary Weight Management Clinic at Our Lady of the Lake Children's Health in Baton Rouge, Louisiana. She's a research scientist on the NIH ISPCTN ECHO network and a co-PI on a PCORI-funded multi-center Pennington trial that will study the dose of behavioral weight management counseling needed to affect BMI in adolescents. She leads our Louisiana State AAP Chapter Committee on Obesity and Nutrition and is a founding board member and vice president of the Louisiana Obesity Society. Dr. Queen has spoken on multiple obesity topics at the state national level, and she has a special interest in equitable access and coverage for obesity treatment. She is also a faculty member for the Louisiana Provider to Provider PPCL Project ECHO, the AAP Childhood Obesity Project ECHO, and has completed the PPP training for primary care providers in advanced mental health with the REACH Institute. She has a special interest in rural and underserved populations, food insecurity, and pediatric mental health. And in her free time, Dr. Queen enjoys meditation, cooking, gardening, travel, and spending time with her husband and 3 daughters in their hometown of Covington, Louisiana. So I will say, having said that, we are in very good hands for today's webinar, and we very much appreciate you being here with us to present on this information. So with that, we will pass control over to you so that we can get started.
Thank you, Brooke. Thank you very much. I am very excited to be here, and it looks like we've got at least 22 participants. And I'm really grateful because I see a lot of the participants are our team members from Our Lady of the Lake. So I work for Our Lady of the Lake Children's Health, and we have a multidisciplinary pediatric weight management center located in Baton Rouge, right attached to the Children's Hospital. And so I want to give a shout out to my team. I see Dr. Holland, I see Aaron, our physician assistant, who's full time with us, and I see a couple other names. I see Dana, our social worker, and Dr. Samant, who's joining us in August. So I'm just grateful that my team showed up today. Also see a colleague up in the north, Dr. Haynes, who started a pediatric weight management center in Shreveport with Willis Knighton. So proud to say that we have two pediatric obesity centers in our state. And then we'll see who trickles in, and this will be recorded as well. So all right. Well, thank you guys for showing up. Let's get started. And this talk is sort of based off of something that I kind of randomly typed up as a checklist for what a pediatrician should try to make sure they cover during an obesity visit. And just to give you an idea how long it takes to get things done, this toolkit that they said that you can download, we started working on it probably almost 2 years ago, and the AAP, their guidelines came out in 2021. And let's see, I think we started working on. I'm sorry, I might be saying the years wrong. I think their guidelines came out, was it 2023? And then we started working on it, but it's taken almost 2 years to get this pared down version to you guys. And the idea is, if you haven't downloaded it, I would go do it while I'm talking. I won't be offended. But the idea was to take a more than 100-page document that the AAP had put together and sort of take out the most important parts and make it more applicable for primary care providers, and specifically pediatric primary care providers in Louisiana. So there's a lot of really good packed in information. And even how it exists, it's still pretty long, but we're hoping through these webinars and through some other type of implementation things, we're going to make it come to life over the next year. So happy to be a part of the Grow Healthy team. So let's get started with some slides, but I am very casual when I present. In other words, I don't want to just talk the whole time. I would love for you guys to ask questions. I would love to stop and pause and interact with you guys if you feel like it. If you want to, you can raise your hand or you can put something in the Q&A. I don't think you can unmute. I think this is a webinar style, so I don't think you can talk, but you can do those other two options. All right, so I do have a couple conflicts of interest, but they will not affect this talk, mostly because they're about medications. I do speak on behalf of some of the manufacturers who make obesity medications, and more, I do it for fun and to sort of spread the word to pediatricians across the country, but they won't affect this talk today. Click on the screen. There we go. And we already got a great introduction. I don't need to go into more, but I do want to emphasize that I practice still as a general pediatrician. I was trained at LSU Pediatrics back in 2012, and I got my board certification in obesity in 2021. So I sort of am new to the specialty world, and I still enjoy taking care of the newborns and the babies as well. Okay, so what are we going to talk about? We're going to talk about what are some of those key actions you should do during a visit. We're going to identify some of the barriers that we have heard that providers feel sort of prevents them from treating patients for obesity in their clinic. We're going to learn how to engage in a very productive, efficient, and patient-centered conversation with the family. And then we're going to review the checklist that's in the Grow Healthy Toolkit. So why does this matter? I don't think you need me to tell you this. If you're here today, you probably understand that obesity is a problem, but just to level set everything, 1 in 5 US children have obesity, and obviously, obesity affects every single part of their body. It's a metabolic chronic disease. There's probably not one organ system it does not affect. And the earlier we intervene, the better. I always like to say that treating the child, or especially the adolescent, is preventing adult obesity. So, how cool is it that we get to be part of both treatment and prevention by focusing on our age group? And so we as pediatricians are, or advanced practice practitioners, or even if you're not a provider, but you're taking care of kids, we have a very unique trust that is given to us from families. And so I really think that the care of children with obesity does not really belong in the specialist office. I really do think that. I think that it belongs in the primary care world. And so that's why we're having this discussion today. So I apologize. I've got this tiny little arrow I have to click, and every time I get off the screen, it moves. So we're going to start with, how do you enter the visit and exit the visit? And I would always say, no matter how much weight they gained, no matter how little they've changed behaviors, it's important to find something tiny, something positive that you can focus on, and start the visit that way and end the visit that way. So I always try to find something positive. I come in the room and I always say, hey, tell me something that's going well right now with your health. And if they kind of shrug their shoulders, I might say, well, what about at school? Tell me something that's going well at school. Anything I can get to start the visit positively, because obesity and weight management, it's a heavy subject. There's a lot of shame, there's a lot of guilt, there's just a lot of heaviness around the topic. And so it's our job to always point out the positives. And I always make a big deal about even little wins. So if they say, oh, well, I walked my dog once in the last month, to you and I, that might be, oh, you could have done way better, right? But instead, I'm going to say, wow, that's awesome. Tell me about that. Tell me where you went, and I'm going to act really excited, because for them, that was probably a huge, mark forward. Whereas for us, our bar might be here. So I think the point is that you should lower your bar and just find any little hint of positivity. We in our clinic order some jump ropes and yoga mats and stress balls and water bottles and things like that. We did get a grant for this, but if you can't afford that, you can always just use stickers. But we do encourage having something to give them if they showed up and they show motivation and interest. I don't reward them based on accomplishment of their goals, because it's really hard. Some of the goals we set are kind of hard. So I would encourage you to reward their journey and reward their effort rather than reward the outcome. And so that's the way I do it in my clinic. If they show up and they engaged in a conversation, I'm like, let's go get a prize at the end. Okay. And I always have them ending the visit with a very clear goal in mind. And we'll talk about that. So, when we think about the weight management visit, I think that some providers feel a little bit lost. Like, how do I talk about their weight? How do I help them to lose weight? Right. And I've sort of divided up the visit into how I would structure it to make it efficient. Now, I don't do this the same way every single time, but this is just a good sort of template for you guys to follow. So I always start the visit with their strengths, HPI, just kind of thinking about what's changed since the last visit. Do you have any questions? Do you have any concerns? I always review the medications, and I always review the problem list briefly. In other words, I want to know, does this patient have prediabetes or diabetes? Does this patient have sleep apnea? Do they have depression, anxiety? Because that's the focus I'm going to have as I'm counseling and coaching them on behavior change. Okay. I'm going to discuss their medical treatment, which might be medications, it might be labs, it might be a referral to a specialist. And then after that, my favorite part is where we get into the nitty gritty of like, okay, what's our plan for the next month? What goal are we going to set? And how can I help you to get there? And I think of myself as a coach, not really as a doctor in that situation, because the doctoring part is done in the first half. And the coaching is really the fine art of motivating them so that they're going to come back to the next visit. And then I might take 5 minutes finishing my note, and care coordination might be me talking to our dietitian or social worker in our clinic and saying, hey, did you know that they said this? Or, hey, my social worker is really good about helping to find summer basketball or helping to find something that will support their goals. So it's important, though, that's the structure of the visit, but it's important that you get the measurements and the actual objective data correct when you're seeing these kids. I cannot tell you how many times in my general pediatric practice, and no offense against our MAs, they're great, but they like to take the shortcuts because they're busy. And so many times I'll look and I'll see that, oh, their BMI jumped up. But then I go ask the nurse and I say, did you take their shoes off? Or did you leave their shoes on or off? And they'll be like, oh yeah, I didn't take their shoes off. So it looks like they got taller. So I'm saying it backwards, but it looks like they got taller because they left their shoes on, and that helps the BMI look lower. And it really makes a big difference in the chart. So it's very important for these weight management visits. Be very clear with your staff that shoes have to be off, jackets have to be off. Even though it's summertime in Louisiana, I know a lot of these kids like to wear sweatshirts. So make sure they take off anything that can be heavy. And then, of course, BMI percentile, blood pressure. Blood pressure is a big issue. So if you're going to start seeing patients more often for obesity, it's important that you have the right size cuffs. And we all know pediatric cuffs often don't fit the patients with severe obesity. And so in our Baton Rouge weight management clinic, we actually had to order extra large adult cuffs and even adult thigh cuffs for some of our most severe patients. And while you might not need that in your pediatric clinic, it is important that if the blood pressure is elevated, that you go back and ask the staff, what cuff did you use? And take a look at it. And it's usually pretty obvious if that cuff was too small. And so you may need to talk to your administration about ordering bigger cuffs. Okay. And then you're going to determine the obesity class. So I think most people or most providers are familiar with what obesity is. Obesity is the 95th percentile or greater. And this is based on the CDC definition in 2022. The CDC also put out this definition of severe obesity being greater than the 120th of the 95th. So you have to look at the extended growth chart, which we have Epic. You have to click the little button to get to the extended growth chart, or a BMI of 35 or greater. So it's either or 99th percentile or greater. Okay, so that's sort of where we were maybe in 2022. But what I want you to learn is I want you to be on the cutting edge of the newest classes. The newest class actually just came out this October, in case you haven't heard about it. And they are more specific as far as including the exact percentile range of BMI. And so there's class 1, 2, and 3, and it's E66.8 with a 1, 1, 1, 2, or 1, 3. So I like to say E66.8 is great. So that's the one you want to pick. So you got to remember that, E66.8. And then you're going to pick either class 1, 2, or 3. Pretty easy. But these, and I've checked with our billing department, these are the preferred codes. They're the most specific codes you can use currently. If the patient has some other cause of their obesity, such as a hypothalamic MC4R pathway cause, a drug such as an antipsychotic, or some of these other more rare causes, you might use that E88.82, E66.1, and then there's some others. But I show you this because the ones that are in red are the ones that I would highly recommend you guys start using if you're not already using them already. If you want to get paid and reimbursed for your visits, it's important that you start to use the most specific codes. All right, so that's all I'm going to say about that. Let's move on to the history. So you've got your vital signs, you've got your correct class of obesity, you've kind of made your diagnosis. You walk in the room, what are the questions you're going to ask them? So it could take a while if you sit there and ask all the questions. If you say, "Oh, tell me what you ate yesterday," and "Oh, how much sleep do you get?" and "Do you watch a lot of screen time?" If you sit there and try to ask all of the lifestyle questions, your 10 minutes is going to be over. So, what I would highly recommend is that you have some pre printed screeners or intake forms that you have ready to go for these weight management visits, and it will save you a lot of time. So, in our clinic, for example, in my pediatric clinic, our staff knows that when they get roomed for a follow up weight, or we call it follow up healthy living visit, then they know to give my follow up intake form. And so when I walk in the room, all those questions about lifestyle are already there. And I may not even go over all of them, but at least I have them to refer to, especially when I'm trying to write up my note and thinking about next steps. In our weight management center, we have a more in depth intake form, and I'm happy to share these forms with anybody after the call as well. So, intake forms for lifestyle history, very important. If you want a quick and easy one, these are freely available on the 5210 Let's Go website. And you can go look them up right now and find for different ages this one page little intake form. I find this is really helpful for a general practitioner. I find them a little bit not as detailed as I would like for our weight management center, but I think this is great for primary care. Okay, so motivational interviewing. And I see the chat is disabled. Brooke, if you could check, it says the chat is disabled. Maybe it's supposed to be disabled.
It's meant to
But
be
you guys can chat in the question and answer section if you would like.
correct.
Okay. So it's supposed to be disabled, Brooke?
Yeah, any questions can go in the Q&A and we'll answer them at the end.
Okay. Yep. Thanks, Kate, for letting us know. Okay. So when we talk about motivational interviewing, I think everyone by now has heard this term, but it's important to know that there's a lot of evidence that motivational interviewing is one of the most effective things you can do to help patients change behavior. So if you have not done any trainings in it, it's, I would say, very, very much worth your time. And some of the questions that I would focus on are the readiness ruler, the confidence ruler, and the importance ruler. And so this is how it looks. Patient comes in and they're just kind of like teenager, pretty much a lot of times not looking at you in the eye. They're often on their phone scrolling during the visit. And I'm just not sure if they're really into this. Not really sure if they want to work on their weight and their health. And so I'll pull out the readiness ruler. I don't actually have a ruler, although I really would like to make one. But I'll just say to them, "Hey, let me ask you a question. So from 1 to 10, if 10 is like you're really, really ready to make some changes, and it's really important to you to be healthy and to not be sick when you grow up. And 0 is like, I don't really care. Like, I am who I am. I'm just going to be who I am. And 5 is like, I kind of care, kind of don't care. Where are you from 0 to 10 today? And it's so interesting because sometimes I will perceive that they don't care and I will perceive that they're not ready. But then the teenager will look at me and say, I'm an 8. And I'll be like, oh, okay, you're an 8. So you do want to talk about this. And so I find a lot of mismatch between their body language and how they actually feel inside about it. And so I really love that. Out of all the motivational interviewing techniques, I love that. I would say the second, my favorite technique for motivational interviewing is probably the role with the resistance. And sometimes you get these patients who truly are resistant and who truly just came in because their parents made them. or the parent is really resistant, right? The parent is coming up with all kinds of reasons why they can't buy healthy food or why they can't, take the kid to the park. And so I will often just sit back and be like, you know what? Like if you don't feel like this is the right time in y'all's life to work on this, like it's completely fine. Like you don't have to come back and see me. I'm here for you. I'm here to support your child's health. I told you, some of the things I'm worried about, but I understand like you probably have other priorities right now. So if you want, you could just call me whenever you need me. And I have yet to have a patient say, you're right, I don't want to come back. So it's something about that reverse psychology and sort of rolling with their resistance and letting them know that look, I'm here for you. I'm not here for me. That goes a long way. And a lot of times they'll be like, no, I do want to come back, but maybe it's going to be in, you know, 3 to 6 months rather than 1 to 2 months. So rolling with the resistance and using that readiness ruler are the top two things I would take to your clinic practice tomorrow. All right, so we're going to speed up just a bit because I'm being wary of the time. And let's see if we have anything. Okay, y'all stop me, Danielle, if you have anything in the chat, just unmute. Okay, so I don't have to keep checking it. So how do we talk about weight? This is a big question that I get from a lot of pediatricians. I speak nationally for the American Academy of Pediatrics and help train pediatricians. And that's one of the biggest insecurities I think that pediatricians have is how do I bring up their weight? How do I say the word obesity? Do I put the word obesity on the chart? And so I would say these are some of my tips. Number one is let the patient and the family lead the visit. It's really important that we don't come in there and say, your child has obesity. And I think that, we need to cut out sodas and we need to get her moving and da, 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 da. So all the things we would do for a general medical visit, I don't want you to do that. I want you to stop, sit back, relax, and just be like the coach. Just be there on the sideline, letting them lead. So if they come in and they say, I want to talk about um, my child's, weight gain, then you can talk about weight gain. Or if they say the word obesity, then you can use the word obesity. But I try to mimic their language, and again, I'm just more of a listener than a leader. Okay, so we talked about focusing on strengths, and it's also important that you also focus on barriers. So I think it's important to realize that when a patient has not changed anything since the last visit, instead of us thinking, oh, well, they don't care or they're lazy, um, well, you could use the readiness ruler, right? Or you could get curious and ask them, why is that? Like, you said you weren't very active since the last visit. Like, what's been going on in your life that has made it difficult for your family to get active? Are you just so busy from school, et cetera, et cetera? So I try really hard not to judge and I try to just be curious. So be curious if they're not making the changes you would expect. And then I focus more on the word health. When I'm talking about goal setting, I'm talking about a health goal, not a weight goal. When I'm talking about the follow-up visits, I try to say let's follow up on your health, not let's follow up on your weight. So I try to get away from using that. And one of my favorite things is rather than saying, "Oh, congratulations, you lost 2 pounds," or rather than focusing on the number on the scale, I often will print the growth chart or I'll turn the computer in the room and show them the growth chart. And I'll just literally explain this is weight, this is height, here's what the BMI means. And then I just get quiet and I say, what do you think about this? And I see how they interpret it. And it's not very hard for a parent to see, oh, the height is here, let's say the 90th percentile, and the weight is here, let's say 140th percentile. There's a mismatch, right? And so rather than focusing on the number and the absolute weight, I'm focusing more on the mismatch between the height and the weight, and without getting into too much scientific BMI stuff. right? So I like to say, either their weight's just growing a little bit fast compared to their height, so we just need to slow it down a little bit. And again, you're being the coach. So I think one of the things that a lot of people ask me, in fact, my father-in-law is here today. I'm surprised if he doesn't walk in the room. Um, and he actually asked me a lot of questions about what I do with obesity. And I think his generation has a lot of stigma, about the parents. Well, why aren't the parents feeding them healthier? Or why aren't the parents getting them out exercising? And I think what's important to realize is that it may not it's first of all, it should never be pointed finger at anybody, right? They already have a lot of guilt themselves. But it's important that you involve the whole family. So many of these families have grandparents that they're visiting on the weekends. They have aunts, uncles, they have, maybe dual households. So it's really important that you invite them all to come into the visit, or you invite them to get on the phone on FaceTime or, verbal. But I would highly encourage you to open your coaching to the entire family. And that's usually going to be a lot more effective than just coaching one parent and one child. And the evidence supports that as well. So, this is a motivational interviewing guide that you can easily download for free. You guys can go right now to that letsgo.org and download this. And it just gives you some more tips on how to do motivational interviewing. For example, that readiness and importance scale. So, we just went through that. And then this is one of my favorite things. This is a app that you can download. It's free. It was put together by the American Academy of Pediatric Institute of Healthy Childhood Weight. And you can go through and pretend like you have a virtual patient and you are the provider, and it has you picking the right thing to say. So it sort of like coaches you and tells you if what you said was maybe not quite in line with motivational interviewing, and then it points you into what you could have said better. So I really love this app. It's all specific to childhood obesity. So if you had to pick one thing, I would pick this. All right. So you're kind of getting towards that end of your visit, and you're going to focus on that goal with your patient, right? And so everybody, I think, has heard of SMART goals, right? They have to be specific, measurable. I forgot what the ART. T is timely. It doesn't really matter. Oh, there you go. Relevant, achievable, and time bound. But what does that mean, right? Like, I don't want to just tell you all this. I want to give you an example. So, one of the most common responses that patients tell me when I say, "Oh, let's make a goal for next visit," and they love to say, "Okay, my goal is I want to lose weight." And I'll just take a big sigh and say, okay, that's great. That's great that you want to lose weight, but how are we going to get there? So let's talk about, do we want to make a goal around eating? Do we want to make a goal around drinks, physical activity, sleep, screen time? I might give them a couple options. And then I help them hone in that goal. So if they say, yeah, I want to get more active, that's still not specific enough. So I'm going to say, okay, well, tell me about your current activity level. Oh, I don't really do anything. Okay, well, what do you like to do? Right? Okay, how often do you think you could do that? And then I'll try to help them make a very, uh, let's see, a range of goals. So I'm not going to have somebody say, I'm going to exercise 6 days a week. I'm going to try to pare that down and say, how about we start with 2 to 3 days a week? And then we're going to sort of inch our way up to the gold standard. So the gold standard we know is everybody exercises every day, 60 minutes or more. But that's not practical, right? So when you guys are making goals with your patients, make sure that you're making them very small, very achievable, and make sure that they're writing them down and that you're giving them some sort of way to track it. A lot of the teenagers like to track in their apps. There's like the MyFitnessPal app where they can track food and they can track activity. But I personally like to just give them a tracking sheet by paper, which I'll also share the one that I like. And that just keeps it right there on their fridge or on their mirror, and they can just every day check it off. I always say that tracking is important when you have a new goal that you're trying to accomplish, but once it becomes a habit, then they don't need to track it anymore, right? Or if they start to get off track, then they need to start tracking. So again, trying to give them rewards for trying, not for succeeding. If they come back and they say, "Yeah, I did it for the first week, but then I got busy," I'm going to be like, "Well, great. That's awesome that you did it for the first week." And I know this all sounds kind of cheesy, and no, I was not a cheerleader when I was in high school, but I tried to bring my positivity to every single visit because that's what the patients need. So we already talked about barriers. We're going to skip over this slide. These are some other screens you might consider if you're going to really start doing this more often with patients. You might want to screen for social determinants. If you had to pick one, I'd pick the food insecurity, just a 2-question screen. If you had to pick a second screen, it'd be the anxiety and depression screen. I see probably more than half of my patients have some sort of mental health concern. It might just be mild, but in many cases, I've had probably once a month a patient come in who has suicidal thoughts that they have not disclosed it to anyone, and they're coming to see me for weight management, but now I have to send them to the ER possibly for suicidal thoughts. And so if you don't screen and you don't ask, they're not going to tell you. And it's very important that you do that. We screen with the GAD-7 and the PHQ-9 ages 10 and up, just to give you an idea. If you wanted to add a third screen, I would pick a disordered eating screen. In our clinic, we currently use the EAT 26. It is 26 questions. So if you feel like that's too long, you can go with the SCOFF, which is a 5-question screener, or the EDEA, which those, it depends on the age group, so it's a little bit more tricky. I would say if you had to have one printed and ready to go, have the EAT 26 printed. And so if anything they say in their history clues you into binge eating, bulimia, anorexia, go ahead and give that to them maybe to leave with and say, "Hey, scan this to me in my chart," or send this back whenever you fill this out, in case you don't have time during the visit. Okay, bullying and trauma, also very important. I don't think you have to do it every visit, but it's important to be aware. So, all right, I've been talking for, I feel like, a while now. Do we have any questions? I'm going to take a quick pause, or you guys can type in the chat. Are y'all still with me? We've got more participants than we started with. We got 26. Okay, can I get a shout from anyone that you're there listening? Because all I see is my video.
Dr. Queen, the chat is disabled, so they won't be able to put it in, but it looks like we did. Yep, looks like we're getting some Q&As that everyone's here.
Okay, you are getting Q&As. I just can't see them on my end, I guess. Oh, I'm clicking on the webinar chat. All right. Thank you, Lacey. Thank you, Kate and Nicole and Kate. Oh, good. We have a dietitian with us. Awesome. Okay, thank you all for responding. I sometimes wonder if I'm just talking to myself. All right, so let's talk about some treatment options. So one of the most important things, if you don't have time to read the AAP guidelines or you don't have time to read the Grow Healthy Provider Toolkit, I'm going to tell you the punchline. The punchline is that the old school way of treating obesity was very stepwise. It was very much like, well, we should start in the pediatrician's office. We should monitor them, try to prevent extra weight gain. And then if lifestyle kind of medical treatment isn't working, then you should refer to a specialist. So it was like a stepwise treatment. And then the specialist would monitor them for like a certain amount of time, maybe offer a higher level of care with a dietitian or a behavioral person. And then if that didn't work, they might refer them to surgery. So it was this very stepwise kind of approach. But what the AAP found after looking at all the evidence is that they want us instead to now offer all the treatment options at the very diagnosis. So as soon as you diagnose a kid with obesity, you should be offering all comprehensive treatment options. And so what does that mean? That means you should offer them intensive health, behavior, and lifestyle treatment. We're going to talk about that in a second. You should offer them anti-obesity or obesity medications, which are currently approved 12 and up. And you should offer them a referral for metabolic and bariatric surgery And technically, the guidelines say 13 and up, although there's some centers that go younger. So let's talk about those treatment options just a little bit more. We don't have time to really go into the details, but we will talk about what that means. So I like to think of it as a pyramid. And this is sort of, these are all the things that we can do to help the child, right? But at the foundation, at the core, is that intensive behavior and lifestyle treatment. So if you haven't listened to Dr. Stayano's talk at the last Grow Healthy webinar, she went into details about what this means. But the highlight is you're coaching on nutrition, on sleep, screen time, all the health behaviors that we know affects weight. And I think everybody should be getting that 85th percentile and higher, which is the overweight percentile. But what I think most people don't realize is that any patient and all patients with a BMI of 30 or above, or 95th percentile or above, or a BMI 27 and above with a comorbidity should be offered pharmacotherapy for their obesity if they qualify according to the FDA, so 12 and up. And I'm going to show you a slide with those medications. And if they have a BMI of 40 or higher, or 140th of the 95th, you should be offering them a referral to bariatric surgery. Okay. And I think that's where we're really lacking as primary care providers, is that because many providers haven't received extra training in this, they feel like, oh, well, I can't really offer them these things. But what I would argue is that the guidelines suggest that the evidence-based guidelines that we should, and I would argue we must be offering these things. If it's not you, then it's you reaching out to one of the centers in Louisiana. Okay. So when we talk about the effects of these treatment options, you can see on the right-hand side that the higher you go up, the more expensive. But you can also see that the higher you go up on the pyramid, the more effective the weight loss. And the truth is that intensive behavior and lifestyle treatment, while it's so important, it's often not going to be enough for a patient with severe obesity that has multiple comorbidities. So if the patient has hypertension, especially like on a medication, if they have sleep apnea, if they have fatty liver, now actually I need to change the acronym. It's now pronounced MASLD. If they have these things, it's important to know that intensive behavior, even at the most intense 26 hours and 12 months, it's probably not going to get them the 5 to 15% weight loss that they need to reverse comorbidities. Okay. And that's really important, because it's not fair to just keep telling a patient to come back in a month, let's keep working on your health goals, and not offer them the more advanced options that would possibly reverse their comorbidities, right? It's very important that we know that what the percentiles to expect. So if you don't believe me, this is straight from, there we go, the 2022 AAP algorithm. This is from the guidelines, and they say, you can see on that right-hand column, 12 and up should get motivational interviewing, intensive health behavior and lifestyle treatment, weight loss pharmacotherapy, and offering referral. Okay. If they're 6 to 12, you can see that they don't necessarily get the weight loss pharmacotherapy, although in our center, we do off-label medication for the most severe patients. So there's the evidence if you don't believe me. So what are those behavioral strategies you should focus on during the visits? This is just a quick list of some of the most evidence-based ones. And if I had to pick, like if I didn't have time to talk about all these, I would say start with sugar sweetened beverages, the healthy plate, my plate portions, and physical activity. I mean, honestly, those I often just go to back over and over and over. Again, I might have a patient just working on those 1, 2, or 3 things and see BMI change over 3 to 6 months. You don't feel like you have to change all of their habits. It's very important that you let them lead. If they want to start with physical activity, great. But if they're like, no way, I'm not doing any physical activity, then I roll with the resistance and I say, all right, well, what would you like to work on? And I'll have them hopefully pick one of these. Okay. So if you're not sure how to have those conversations, if you're not sure what my plate is and you just don't know, This is a great guide. It does cost a little bit, but it's not very expensive. And this goes over what that conversation might look like with those patients. And these are little cards that you can have in the room to kind of guide the conversation. You can go to the main health. Let's go. I know the pediatrician who made this. It's pretty. Okay, and so the final takeaway is that your patient is the captain of their sailboat. Anybody who knows me knows that we as a family are going to go sailing around the world in the next couple years, and so I try to think of it like let you are there to help sort of point them in the direction of where they're trying to sail, but let them go zigzag. Let them sail the way that they want to sail, and you just kind of sit back and encourage them. Okay, but sometimes you do all the things, and maybe they were even in an intense program, and their BMI goes up. They gained weight. Even the most motivated patients, this can happen to. And so I want you guys to understand that obesity is so much more complicated than I ever understood. And it's more complicated than I still understand because there's a lot of hormones that interact between the GI system, the fat cells, and the brain. Okay. And if any of this gets dysregulated, then it's going to fight against weight loss. Okay. So, for example, if your patient is really cutting back on soda and increasing their activity, the body might initially lose a little weight, but then guess what's going to happen? You see that ghrelin hormone over on the left hand side of the screen that's coming out of the stomach? Our body will fight the weight loss and increase the ghrelin. Ghrelin makes you hungry. So now, have you ever noticed if you work out a lot, all of a sudden you're really hungry for the next couple of days? So our body fights weight loss, and that's just a physiologic truth, right? And so it's important to know that these things are happening in their body, and it doesn't mean that they're failing or they're not trying. Okay. It also turns out that energy in or calories in do not meet equal calories out. I think when I was in medical school, I think I was taught that. But it's important to know that that is actually not true. Okay. Lots of really smart scientists have debunked that myth. And why is that? Because we all have different engines, right? We all are born, some of us with like that Volkswagen, like slow, creaky engine where we eat pizza and it just stays on us and we can barely go 10 miles. And then there's the race cars, those skinny people who they have super efficient engines and they burn their fuel so quick and they burn it all off fast. This is just a metaphor, but the point is that we're all built differently, and a lot of it has to do with our genetics, our epigenetics, and our physiology, and our environment, right? And so it's not fair to just assume that if they cut out on donuts and if they exercise more, they're going to lose weight. That's just not true. I'm here to tell you that. Okay. Which is why we often need to consider medication, right? The brain and how we process our hunger signals, it comes in three main parts of the brain, but the hypothalamus, which is the brain stem, is really where most of our hunger derives. And what I want to point out is that people think that children and families and parents are choosing or not choosing healthy choices. And the truth is that that prefrontal cortex, it's not really developed in the kids, right? Until they're probably 25. And even if it was developed, even in the adults, that's not what's really driving their eating habits. It's the hypothalamus and it's the limbic reward dopamine system that's really driving behavior choices. And so when a patient is still choosing the soda, even though you counseled them on the soda like 5 times, it's their brain that's driving it more than it is their choice and their prefrontal cortex. And that's probably the most important thing I'm going to say this whole time. So here are the principles of compassionate obesity care. We're reaching the end here. Number one, obesity is a chronic inflammatory disease, affects multiple organ systems. That it's complicated. The brain and the organs, they all interact. There's even a board certification. That's how complicated it is. It's not just calories in and calories out. And the human body loves to defend its highest weight. It loves to regain the weight. And so we have to start to think about it more medically so we can treat the underlying physiology and biology. And we have to stop having that thought that it's the patient or the child or the parents or the grandparents' fault, that we cannot be the ones who perpetuate that guilt. There's enough of that out there in society. We as medical providers need to provide compassionate care. We also need to offer longitudinal treatment, which means like this is not a one and done kind of visit. Like you're going to hopefully see these patients for a couple years before you're really going to start seeing their BMI come down. I would say in general, I can say with every 1 to 3 month visits, I can see the BMI change in 6 to 12 months. That's how long it sometimes takes. With medication, it might be shorter. It's important to always think about the mental health comorbidities, the social determinants, the social drivers of health, and of course, use motivational interviewing. If you're going to pick labs, there's 3 I want you to know. Those 3 labs are, drum roll, A1C or a fasting glucose. I prefer the A1C, a lipid, and an ALT. Okay, so actually the ALT, AST, they come together, but the ALT is the one that's usually elevated with fatty liver. So those are your bare minimum. And for me, it looks like a lipid panel, a CMP, and an A1C. Okay. If you're not sure how to interpret them, then we'll probably have a whole nother webinar just on that. Okay. You should also consider referrals, even if you don't have one in your clinic, to a dietitian, a PT, or a behavioral health specialist. And you should always consider follow-up in 4 to 12 weeks. I always give them the choice. I say, hey, would you like to come back and see me in 1, 2, or 3 months? I would love to come to see you back. It's important that we say to them, I would love to see you back and partner with you on your health. And I would love to check on you in a couple months. When do you want to come back? Again, throwing the ball in their court and making them feel invested. All right. So I think we're almost to the end here. Screen is paused. This is just showing that what I just told you about those 3 labs, it comes straight from the guidelines. I'm just trying to simplify things for you. Thyroid, vitamin D, CBC, insulin, they're all optional, I would say. If there's enough evidence to do it, if they have thyroid symptoms, I would do it. I would not check an insulin level because they vary throughout the day and they don't really help you that much. You can see their acanthosis and often know that they have insulin resistance that way. I only order a CBC if they're very picky, and I order a vitamin D on almost everybody, but mostly because I'm curious and I'm already poking them. And I would say more than 75% of patients have deficient vitamin D. Now, for the sake of time, I am not going to go through these tables. I just want to show y'all how cool our toolkit is, that we have put together exact referral criteria. This one actually is put together by the FMOL health system. And this is when I refer out, okay? And it'll be there for reference. If you want to know, when do I refer to a gastro? When do I refer to cardiology or endocrinology? It's all going to be there. And if you're not aware, the Louisiana Obesity Society is a really cool way to network with other providers like you who are interested in obesity. And we have a sliding scale sort of for depending on what level you are in your training. It's free for residents, so spread the word, medical students and residents. And we have our annual conference coming up in person. This picture shows Dr. Shower and the Lieutenant Governor and I on a panel discussion. We do a lot of advocacy. In fact, the Lieutenant Governor invited us to his apartment on June 4th, where we're going to have an advocacy breakfast. So anyone who wants to come is invited. We're going to be spreading out the registration soon. We also have a committee on nutrition and obesity through the Louisiana AAP. And the national AAP, American Academy of Pediatrics, has a section on obesity that does cost some money. To be on the Louisiana committee, it's free. And I think, oh yeah, I want to tell you about this Project Echo that the AAP is offering. This is what I was mentioning that I help teach for the AAP as faculty. And this is open to providers across the whole country. And we have every 2 weeks a different topic. we're about halfway through. It's going to go to the end of July, but it's not too late to sign up. And it's myself with several other experts. We have a psychologist, we have a dietitian, we have two other obesity medicine providers. So it's a great resource. And then if you want a more intimate sort of like this, Project Echo, this is another case-based learning model where we work with just Louisiana providers. So Dr. Haynes is faculty, and we have a couple other faculty out of New Orleans, Dr. Hauser, and we talk about real life Louisiana cases, and we just kind of discuss them, and we have a little learning topic each time. So this is happening, actually coming up again in July. And we are thinking about merging this with Grow Healthy and making it more often if we can get more interest. So that's coming up, sign up. And finally, the toolkit, if you haven't downloaded it, do it. It's really good. And I hope y'all read at least part of it because we spent a lot of time on it. And then this is just a pathway that we created to decide when do you as a primary care provider refer to a specialist like me and our clinic. And I would argue that if their BMI is above the 120th percentile, or they have a serious comorbidity, you would either e-consult us, which would allow us to see the chart and give recommendations, or you would consider referral, or you can call, text, email, because we are very approachable. This is our clinic flyer. You can find us on the web. And that's it. This is a QR code. If you're interested in more free tools, I love to share things that I create. So I have a billing and coding guide. I have all kinds of things up on this Google Doc. So you can scan it, answer the survey, and I'll go back to so you can scan it. And you guys can reach out anytime. So that's all I got. We got 2 minutes left. Let's see if we have any questions. Thanks, Dr. Holland, the queen of positivity. I try. And Nicole says, what if referrals are not available in the area, especially for Medicaid? So Nicole, I'm not sure if you mean referrals to like GI, cardiology, endocrine, or if you mean to obesity medicine doctors like myself. I would say it's probably not as hard to get into the other specialists. If you're trying to get into an obesity medicine provider, we have a nice little network that we formed across the state. I have some providers in Lake Charles, Lafayette, Shreveport, New Orleans, Baton Rouge, and the North Shore. So depending on where you are, if you reach out, we can probably get that patient to the right center. And if not, if the wait list is too long, we can give you tips on how to approach the treatment.
Thank you for everyone for attending live, and we will be posting a recording of the talk on our website. So please be on the lookout for that. And Daniela, can you please advance to the next slide? Just as a quick reminder set again, our next webinar is on July 17th. And our conference, Be the Reason Kids Grow Healthy, will be October 2nd and 3rd. And then this is all of our socials. So please follow us. We would love to hear from you, what y'all would like to see in the future. And we are 1 minute over. So thank you everyone for attending and hope you have a great day.